Hello class, how are you? We are talking about chapter 23, second part, trans ischemic attacks, TIAs, on page 529 in your med-surg book. All right, TRAs are a warning sign of a stroke. And about 11% of people who are diagnosed with a TIA will have a stroke in 90 days. So strokes are very important for us to learn about because it's a major cause of morbidity, mortality, causing people to have to be in rehab centers. And so we're going to talk a lot about them in the next few minutes. A TIA is a brief interruption in blood flow, warning of a more serious neurological event. Symptoms generally last no more than 1 hour and completely resolve without residual deficits. So do a thorough history on your patient who presents with symptoms of a TIA. Do they have high blood pressure? Do they have high cholesterol? Are they a smoker? Do they have diabetes? Do they have other risk factors for stroke? And that will help you guide in treatment for that patient. Several different tests can be done for them. A carotid duplex ultrasound to find out, is a carotid artery blocked? And of course, in a checkup on a patient who is at risk for stroke, they should be having a stethoscope placed on the carotid artery to check for a bruit, to see if there's a whooshing sound or bruit, to see if there might be some narrowing, because that's where most strokes occur, is in the carotid artery. So is there narrowing in the artery? So this carotid duplex ultrasound might be done to find out, is blood reaching the brain? Is that the reason why they had the TIA? Also, blood tests can be done, MRI, EEG, which is electroencephalogram, measuring electrical activity in the brain. So as far as if there is a blockage, there can be an endarterectomy to remove the blockage or a stent placed in the carotid artery. Now, unless there is over a 60% occlusion, then this surgery will more than likely not be done. The patient will be counseled in diet modification, lifestyle modification, returning to some exercise, stop smoking, control the blood pressure, to see if they can change what's going on with that. So as far as a cerebrovascular accident or a stroke, another term that's getting popular for a stroke is a brain attack. And we are going to review, before we leave today, about FAST, and looking at that and trying to decide if someone's having a stroke and being able to teach that to children, because a lot of children are with adults, particularly in the summertime, that are at risk for stroke. They're staying with their grandparents, or maybe they're staying with them right now because of what's going on with the virus, but we need to teach children how to recognize stroke also. So a stroke, or a CVA, is an interruption of blood flow to the brain. Smokers are at a more great increased risk. Also, African Americans are at a much higher risk for stroke. It's the fourth leading cause of death and a leading cause of disability. As far as pathophysiology, it could be a thrombus or a clot causing the stroke. It could be an embolus, which is a traveling clot. It could be a hemorrhage that causes the stroke. Or it could be pressure on a blood vessel from a growth that's in the brain. A hemorrhagic stroke or tumor is less risk for stroke, but it is still a cause. In your book on page 530, there is a green health promotion block that talks about those who use cocaine or methamphetamines are at a much higher risk for stroke. Be sure and read that section to caution people about the dangers of using cocaine or methamphetamines. There's a 5-fold increase in the incidence of stroke among these individuals who are using these drugs. Okay. So first off, let's look at modifiable risk factors versus modifiable risk factors. So modifiable risk factors for strokes, this is in your book. It's going to be controlling your blood pressure, controlling weight, stop smoking, stop drinking too much alcohol, try to control cholesterol by taking the cholesterol medication that's prescribed and taking blood pressure medicine that's prescribed for high blood pressure. Non-modifiable risk factors are age. As you age, you are more at risk for stroke, unfortunately. Also, race, as I said, African Americans are more at risk, and men are more so at risk for strokes also. And if it's in your heredity for strokes. If grandparents had a stroke, ask someone about that in their history or their parents so that you can be sure and document that in your records. All right, causes of a hemorrhagic stroke can be a cerebral aneurysm or an arteriovenous malformation. So as far as an aneurysm, this is an abnormal ballooning of an artery wall, and it causes severe headache. An arteriovenous malformation or AVM malformation is a congenital abnormality that is a tangled mass of malformed, thin-walled, dilated vessels that form an abnormal communication between the arterial and venous system. So what happens is this leaks, causing the hemorrhage. I actually knew a 12-year-old girl that was in the hospital at Erlanger several years ago who had an AVM malformation, and she ended up having a massive stroke. She did live and went under probably a year of rehab for that, but she survived that episode, but she did have this AVM malformation. So, warning signs of a stroke. Teach people to seek immediate medical attention if any of the following signs of stroke appear: sudden weakness, numbness, tingling, or loss of feeling in the face, arm, or leg, trouble seeing in one or both eyes or double vision, sudden confusion, slurred speech, trouble talking, difficulty understanding what others are saying, a sudden severe headache for no known reason, sudden trouble walking, dizziness, or feeling of spinning around, loss of balance or coordination, or blackouts. And I wanted you to pay attention to a few terms if you'll look them up in your book. Hemiparesis is another term for weakness. Paralysis is another term for hemiplegia is a term for paralysis. And poor coordination, ataxia, is another word for that. So if any of these warning signs occur, ask the person to smile, shrug the shoulders, repeat a sentence, or saying what you say first, or tell you who he is and where he is. And you can kind of think of this as the word fast. I mentioned that just a few minutes ago, but ask the person to smile, see if they have a facial droop on one side. Have them raise their arms and see if they have one of the arms that droops downward. Can they say a short little riddle that you ask them to say? It may not be something as difficult as Peter Piper picked a peck of pickled peppers, but something like that, or just to repeat a sentence that you have said. Also, what time did the stroke symptoms occur? This is very important. Of course, they need to get help as soon as possible when they recognize or when the family member recognizes that they're having symptoms of stroke. This is very important for treatment, which we'll talk about in just a second. But that's something you can teach children about fast. So, face, arms, speech, and time. Okay? Stroke diagnosis. As when we were talking about TIAs, an MRI or cerebral angiogram can diagnose a stroke, an EEG, brain scan, transcranial Doppler flow study, carotid artery Doppler studies, testing for blood levels of glutamate. This is a excitatory neurotransmitter in the brain that will be in the bloodstream during a stroke. So that's definition for that. And in a lumbar puncture, there'll be blood in the cerebrospinal fluid with a stroke. Now, your patient who has had a stroke, they possibly might have some of the following symptoms: bladder and bowel incontinence, spatial perceptual deficits, emotionally liable responses, motor function deficits, language disorders. So your patient may have bouts of crying, bouts of anger, teariness because of they aren't able to do something that they want to do. Also, if their stroke is unilateral, then they may neglect the injured side of their brain. If you look back, it's really interesting if you read through the chapter and look at where strokes occur in the brain, and that there is a crossing of vessels in the midbrain, which has to do with why if there's an injury on the right side, there's paralysis on the left side, and vice versa. So if they do have this hemiparesis or hemiplegia on one side, they may tend to neglect that side because they're just not able to feel it or control it. So they can very easily hit their arm on a doorway or injure their leg or something like that. So teach them about not neglecting the injured side. They may also have dysarthria, which is a difficulty speaking due to tongue problems and movement of the tongue, which we'll talk more about in a second. Okay, stroke treatment. So you do want to treat the high blood pressure with someone who's having a stroke, but it's kind of tricky because you want to lower the blood pressure, but you don't want it to be so low that their brain is not being perfused. So that is kind of tricky with the treatment, but you do want to place oxygen on the patient, maintain their airway, make sure that they have 2 IVs flowing for medications, and raise the head of the bed 30 degrees. So if you're out in the public and stroke symptoms happen, just maintaining the airway best you can and elevating the head if they don't have an injury. Also, temperature control of the patient, controlling fluids and antihypertensives, systemic tissue plasminogen activators. Surgical procedures can be done to retrieve the clot during angiography as a possibility. And as the person is recovering, you want to keep their body in good alignment to prevent contractures, and also be aware that they might have spatial perception deficits. And complications of stroke can be that they're more prone to have a second stroke. So major complication is watching out for restlessness in the patient, or something to watch for rather, is to watch for restlessness and signs of increased intracranial pressure so that they don't have that second stroke. Also, seizures can be a complication of stroke, and hydrocephalus. Now, I'm sure you've heard about TPA before, lowercase t, capital P, capital A, and you want TPA to be given within 3 to 6 hours of stroke symptoms, but it's not to be given if they are at a bleeding risk. So that is why it's so important for someone to seek help as soon as they have the stroke symptoms, because you want treatment to be given optimally within 3 hours of the symptoms of stroke. And those are clot busters that we'll talk about when we discuss pharmacology. All right, as far as treatment of the patient in stroke, your book talks about phase 1, phase 2, phase 3. Phase 1 has to do with assessing the patient. We just talked a little bit about this. Maintaining an adequate airway, establishing baseline data regarding vital signs, level of consciousness, neuromuscular function, and neurological status. So during doing your neuro check, with checking your vital signs, checking the hands, checking to see if they can squeeze your hands, can they use their strength to pull on your arm? Can they push against your strength? And checking the cranial nerves could be important too, but in just doing the regular neuro check, checking those things out, asking them questions. Who are you? Where are you? Do you know what day it is? And preserving joint and muscle function, preventing complications that may interfere with rehabilitation. Also in phase 1, what amount of activity can they do now? What are the restrictions? And what was the cause of the stroke? Do they have difficulty swallowing? Are they having trouble talking? Sometimes the phases can overlap when you're phase 1, phase 2, and phase 3 of stroke rehab. Plans for rehabilitation should begin the moment the patient is admitted, and various members of the healthcare team collaborate with the patient, such as your occupational therapy, speech therapy, physical therapy. And as I said, patients who have had strokes can be prone to rapid mood swings and spontaneous weeping. For home care, certainly discharge and referrals are necessary. Home health care, continued rehabilitation to a facility possibly. Educating the patient's family about stroke symptoms, because we want to avoid the second stroke from happening. So good education to the family and lifestyle modifications. Also, and educating about medications. And when you're thinking about nursing diagnosis, think about safety, think about the patient falling. There maybe have some paralysis, so think about skin integrity. Think about their nutritional status, if they're not able to eat on their own. And you've got lots of good examples in your book of nursing diagnosis as well. Also think about their urinary functions, bowel function too. Okay, so let's move into the last part of chapter 23. First off, talking about briefly brain tumors. They can be primary, which means that they originated in the brain, or it can be secondary, which means that it has traveled from a different part of the body, such as a woman who has had breast cancer and she has metastasis to the brain. The person that has, one of the number one symptoms for brain tumor is a severe headache that awakens someone from sleep, also having vomiting and visual problems. This person, as far as treatment, can have surgery, radiation therapy, which will last for weeks and weeks. They can have an implanted catheter for targeted radiation chemotherapy or chemotherapy. And as far as surgery, just like the young lady that I mentioned that had this AVM malformation, she had a piece of her skull removed, and they removed the malformation, and the same thing could happen for someone who's had a brain tumor. They can have a window flap, it's called, placed into the skull to remove as much of the tumor as they can prior to having radiation or chemotherapy. And it may be that they can't remove all of the tumor. Nursing management of patients with brain tumors. Routine neurological assessments, of course, are important, including the activities of daily living. Assess that. Pain assessment and control. And your nursing diagnoses will have to do with pain, anxiety, and seizures. Okay, also your book talks about bacterial meningitis and viral meningitis. Bacterial meningitis frequently follows an upper respiratory infection, and this is on page 544 or 543 in your book. And usually in bacterial meningitis, the infection is spread from the spinal cord to the brain. And you've got a couple of tests you can do on your patients on page 544. In figure 2310, the Brodzinski sign and Koenig's sign, which has to do with in the Brodzinski sign, if the head is moved towards if the chin is moved towards the neck, the head is flexed, then the patient will want to flex their knees also. And if the Koenig sign is positive, then they are going to be unable to extend their knee fully because of pain and spasms in the hamstring muscle. So look at that on page 544. And this patient will complain, as far as bacterial meningitis, of fever and headache. They'll have nuchal rigidity. And in meningococcal meningitis, they'll have a petechial rash, and this can be diagnosed with a spinal tap. So what will happen to diagnose the type of meningitis? They'll look at the organism that's present in the spinal fluid. And the patient will be given antibiotics, steroids, anticonvulsive drugs, and analgesics for headache. And in viral meningitis, it is milder than bacterial meningitis. They can have some similar symptoms. And as far as nursing management, you just manage the symptoms that they're having. Monitor the patient for increased intracranial pressure doing neurological checks on your patient, and watching for worsening of symptoms. And you want to conserve the strength of your patient, prevent seizures, and promote healing. Your patient will be on droplet precautions and standard precautions. And also, something you may not think of first off, but the patient who has meningitis can have decreased peristalsis due to the disease process. So be sure and listen for bow sounds, and just do an assessment of elimination of what's going on with your patient. And encephalitis is a direct infection of neural cells. So when you talk about encephalitis, most frequently you think of protecting against mosquitoes and ticks. So because they are vectors that carry this, or it can be a complication of chickenpox, mumps, or measles. And this patient will have a stiff neck and photophobia. And to diagnose, their virus will be found in the cerebrospinal fluid. They have flu-like symptoms that progress. They can have some paralysis, which could become long-term, or a brain injury could result from this. So I wrote down in my notes to be sure and wear your bug spray, because you don't want to get this virus by being bitten by a mosquito or tick. So teach your patients about wearing good coverings when they're in an environment where that might happen. Other brain disorders mentioned in this chapter are brain abscess. Symptoms of this is fever and headache. It could be caused from a laceration to the scalp, head injury where a pathogen invades and causes an infection, or cranial surgery where a bacteria gets into the brain. Also, your book talks about headaches and migraine headaches. That's one of the number one, if you go to work in just an internal medicine clinic or family practice office, headaches are going to be one of the most frequent complaints. And it can be a complaint of so many different disease processes. Cold compresses, of course, analgesics are good for headaches, but kind of asking your patient a little bit more about the headache can help you decide about it. If they are having a lot of pain in the back of their neck and upper back or lower neck muscles, that's a tension headache, okay? Cluster headaches are more common in men, and they have to do with the trigeminal nerve. And migraines, sometimes people have an aura prior to their migraines. They can make someone physically sick, have some vomiting, cause them to have to go to bed for several hours because they just can't function with this severe migraine. They can even have some loss of vision or disturbance in their vision with migraines, but they need to look for triggers. Many times with a migraine headache, chocolate, caffeine can trigger that. MSG in foods also can trigger it. So they need to try to discover what their triggers are. And there's a lot of good medications to take for migraine headaches also. Also wanted you to look at trigeminal neuralgia or tic douloureux. And it is when a person has, usually a person who's about in their 60s, they have severe facial pain, and it has to do with the fifth cranial nerve on one side of the face. They will guard this area big time. So if you're taking care of a patient who has trigeminal neuralgia and you go to try to bathe them and they'll even block you from touching their face. They don't even want a washcloth to touch their face because it can cause these brief stabbing muscle pains. They're prescribed anticonvulsants for this, and unfortunately they can have this occur quite frequently in their lifetime, so they'll have to be on a medication regimen for that. And Bell's palsy, it's edema and ischemia of the facial nerve caused by the herpes simplex virus. It is more common when someone's stressed or exposed to cold. Even stress from pregnancy can cause Bell's palsy. I've seen that a couple of times in patients. They'll have a unilateral weakness of the face, and they can lose their blink reflex. They will almost look like a patient who's had a stroke, because if they smile, then half of their face is just drooping, and they can't close their eye. So you can use an eye patch to cover the eye so that the eye doesn't become so dry. And they will have to do corticosteroid therapy for 6 weeks to 3 months. It can last that long sometimes. And it can unfortunately reoccur with this patient also. All right, so that is chapter 23. And next time I see you, we'll be going over chapter 24. Thanks for your attention.